infarction, the most commonly occluded coronary arteries are the left anterior descending. It's more commonly occluded than the right coronary artery, which is also more common than the circumflex artery. For the symptoms of myocardial infarction, we could have diaphoresis, nausea, vomiting, severe retrosternal pain, and then pain in the left arm and or jaw, the classical distribution. That's the classical distribution of a myocardial infarction, and shortness of breath and fatigue. So we're going to talk about the changes in different periods of time. So we have from 0 to 24 hours, then from after the 24 hours. So basically from the end of 24 hours, that is after the first day till the third day, and then from the third day till 14 days, and then from basically 2 weeks to several months. So at first, for 0 at 24 hours, on the gross appearance of a heart, we would find, of course, here an occluded artery. There you go, this is the occlusion. And this is the infracted area. It looks like it has dark mottling, pale, with tetrazolium stain. So the tetrazolium is an external stain that we can add to a tissue to know how, like what color does it start to have. So in our case, in myocardial infarction, at 0 to 24 hours, it would look pale, the infracted area. So that's for the gross appearance, while under light microscope we can find wavy fibers. They start to happen like from 0 to 4 hours only like 4 hours. So, but it also develops early coagulative necrosis, that is from hour 4 till 24 hours, and it's in the histological image here in photo A. What happens is that the cell content released into the blood, of course, because there's an infracted cell, so it's dying, so there is some kind of dissolution or degradation, and its content is released into the blood. It would also lead to edema, that is the collection of fluid into that place, and then hemorrhage, of course. So we could have as well something called reperfusion injury. It's where there are free radicals and an increase in calcium influx into the cell, which, of course, as we know, that calcium has a major impact on the contraction of a smooth muscle. So that influx of calcium would lead to hypercontraction of the myofibrils, and we're going to know why in a minute. It will also have the hypercontraction of myofibrils would definitely look like dark eosinophilic strips. So that's for a light microscope. For the complications, we could have ventricular arrhythmia, so as we said, or heart failure. So what we said is that the most common cause of sudden cardiac death after someone is having a myocardial infarction, it could be ventricular arrhythmia. So if someone died after an MI, a myocardial infarction, if they died at home, then the most common cause could be ventricular arrhythmia. But if that patient makes it and comes to the hospital, then the most common cause of dying after myocardial infarction at hospital is heart failure. And also cardiogenic shock. I think I read that about in New World or something like that. Yeah, so that's something to be sure about. Someone to make sure. So for the 0 to 24 hours, what are the changes we're going to see? For the 0 to 24 hours, we're going to see nothing basically, but of course there's a risk of arrhythmia that may cause death at home, as I said, or heart failure, and also cardiogenic shock. We see nothing because it takes time for sufficient leak and activation of intracellular enzymes. Because 0 to 4 hours is a really short time. We need more time for the cell to rupture and let all of its content go to the outside. So, but what happens is because now this area is infracted, it doesn't get blood, as we can see here, it doesn't get blood in the vessels, so it's a state of hypoxia. So the hypoxic environment causes an anaerobic respiration, leading to a reduction in the ATP. Because this is hypoxia, so there should be an anaerobic respiration. It leads to a reduction in the ATP and an increase in lactic acids. And there's, of course, an increase in the lactic acid. We know that under anaerobic conditions. So without the sufficient efficient ATP, we lose the function of this channel, of this pump or whatever it's called. It's the sodium potassium ATPase. So, because it's not working anymore because we lost the ATP part, so it's not functioning. So we accumulate the extracellular potassium. Potassium is going to stay outside the cell. There you go. The potassium is going to stay outside the cell, which means that is the reason why we could have arrhythmias, because potassium is responsible for the arrhythmias and everything. So if it accumulates outside the cell, it's not coming inside the cell because we lost the ATP, then it's arrhythmias. So in addition to that, if the potassium is not going in and the ATPase is not working, so the sodium also stays inside the cell. It doesn't go outside the cell. So it stays in the cell. And in addition to that, there is a calcium also in the cell. So we have the sodium, calcium, they stay in the cell, which they will do is actually pull in water, causing edema. The edema, that is the accumulation of water. So the heart stops beating in a minute, okay? After those 4 to 24 hours, the contents coagulate with unstable plasma membrane of cardiomyocytes. So that's when the start of coagulative necrosis, okay, the early coagulative necrosis. Because the contents, as we said, coagulate with the unstable plasma membrane of cardiomyocytes. So we will see the lactate dehydrogenase and creatinine kinase MB and the troponins. These markers, because now the myocyte is dissolving and a lot of changes are happening, so these are secreted into the lymphatic system, and also then they enter the venous system. That's how we can examine the blood and check for these markers and know if this patient started to have a myocardial infarction or not. So for that's it. For the tetrazolium stain, as I said, it binds with the LDH, the lactate dehydrogenase, strongly. It binds strongly. So you can see that the infracted area lost its LDH. So as this infracted area has disseminated its LDH into the bloodstream, that means it's losing the LDH. In that case, the tetrazolium cannot find the LDH for it to bind to it. That's why it would look pale. So it would not stain. That's why we said it is pale over here. The hypoxia itself is going to cause release of hypoxia-inducible factor, which turns on inflammatory genes and causes production of vascular endothelial growth factor. So, because this is a state of hypoxia that we're having now, this hypoxia itself would lead to turning on some inflammatory genes that would start the process of inflammation. So that starts with the production of VEGF, that is the vascular endothelial growth factor. The first cell to respond to this inflammation or the start of inflammation will be the PMNS, and it is the polymorphonuclear cells. So the polymorphonuclear cells are the first to show up in the 12 to 24 hours. This is the key for reperfusion injury. So if we're given oxygen here at this point, it will cause these neutrophils to make ROS, and that the ROS is reactive oxygen species. So at this point, the oxygen, when it comes to that infracted place, it will make these neutrophils to utilize that oxygen and make the ROS out of it. The ROS are reactive oxygen species, and it's definitely a bad thing. So another thing delivered here through during their perfusion while blood starts going back there is calcium. So because we know that calcium is responsible for contraction, so it causes the sarcomeres in the myocyte to contract, And without ATP, because it's contracting, we have calcium, so it's contracting, but at the same time, we don't have ATP. It's without ATP. So after contraction, the myosin head, that is a teeny tiny part of the muscle fiber, does not uncock. So let's say it contracts, but it cannot relax. It contracts because there is calcium, yes, but there is no ATP to finish the process. So the contraction band necrosis occurs. And that's why we say here that we have hypercontraction of myofibrils. So yeah, this is for the 0 to 24 hours. And then we have over here the 1 to 3 days. 1 to 3 days, we're going to have hyperemia. That's for the gross, of course, appearance. While under the light microscope, we can see extensive. It's not just early, because this is from 1 day to 3 days. We're going to see extensive coagulative necrosis, and the tissue surrounding infarct shows acute inflammation in neutrophils, because already in step 1 we started the inflammation process. So now we're going to see acute inflammation with neutrophils. This is the image for it. And then okay, we're gonna see the complications is post-infraction fibrinous pericarditis. So it's fibrinous pericarditis. Well, we know that itis means inflammation, and fibrinous is because everything is disrupted, and we're gonna try to make changes in the structure. And post-infraction, of course, so that's happening after the infraction takes place. So from day 1 to 3, we see many neutrophils and necrotic debris. We see, okay, that's inflammatory part, and necrotic debris is because this cell, the myocyte, is just degrading and dying. Now, the coagulation necrosis, which is the coagulation necrosis that we talked about, is denaturing the intracellular contents. The intracellular contents is just disrupted. So the cytoplasm and nucleus blur together, but the membrane is intact. So if this is a normal cell, so this is the cell membrane, and this is the nucleus, and these are the cytoplasm contents, that's all normal. But in our condition, the cell membrane still stays intact. That's good, cell membrane, it's fine. But the cytoplasmic contents and the nucleus just gets messy all together, and they blur. They just go one into another, and you cannot differentiate, like this is the nucleus and this is the other part of the cytoplasmic contents. So the new complication here is fibrinous pericarditis, as we said, because the inflammation from the neutrophils can extend to the pericardium. Of course, because the inflammation, because we're having a lot of neutrophils, as we said, and necrotic debris, it will not just stay at its place. It can extend to the pericardium. That is the outer lining or outer coverage of the cardiac muscle. Now, let's go for stage from 3 to 14 days. And in the gross appearance, looks like hyperemic border, of course, with central yellow-brown softening. So there's central yellow-brown softening. If you can take a look at the color change over here, it would make sense a little bit. So for under light microscope, we're going to see macrophages at this point, not just neutrophils, it's macrophages. Then the granulation tissue out margins. Then there is a granulation tissue out margins. That's why the histological image looks different from the first and second one. So for the complications, we could have a free wall rupture. If we are having a free wall rupture, then that will develop into tamponade, because like the contents that will flow through the rupture would go and just be right there around the heart, preventing it from contracting, and that's how we have cardiac tamponade. But if we have papillary muscle rupture, that is the muscle that is responsible for attaching the valves, like the aorticoventricular valve, or I mean whatever valves in the heart itself, mainly the mitral valve and tricuspid valve. So if we have those muscles to rupture, and that would lead to mitral regurgitation. So basically we're talking here about specifically the mitral valve. So if its papillary muscles rupture, it will lead to mitral regurgitation. Of course, the muscle that was attaching it so tightly would rupture, so it definitely will get flappy and turns into mitral regurgitation. So what also we have, all of these are possibilities of rupture. Okay, so the third thing is interventricular septal rupture. So it's the septum between the two ventricles. Okay, so it's this septum. If it ruptures then it would happen due to macrophage-mediated structural degeneration. It may rupture because the macrophages start doing some processes that would cause this structural degeneration. If it happens anyway, then the shunt is going to be, because now we have VSD, but this VSD is after an MI, a myocardial infarction. So it would be a left to right shunt, because as we said, the blood moves from the area of the heart that has the highest tension or highest power, and the left side is stronger than the right side. So definitely the blood will flow from the left to the right side. Also, one of the complications is we could have left ventricular pseudoaneurysm. So this is different. We need to pay attention that at this point it could be only a pseudoaneurysm. So it has a risk of rupture. The pseudoaneurysm would lead to risk of rupture. For day 3 to 4, now the PMNS, which we said were the polymorphonuclear cells, okay? The polymorphonuclear cells, they need help, so they call in backup for monocytes. As soon as they call the monocytes come, but as soon as they get to the area that we're talking about of the infraction, they become macrophages. Now they are called macrophages instead of monocytes, okay? So that's their new name. That happens upon accessing the extracellular matrix tissue. This access is granted or helped or facilitated by the vascular endothelial growth factor from earlier, because we said that we have it here. We said that we have vascular endothelial growth factor probably from the first 24 hours. So it was there. That's why it would facilitate and grant the presence of macrophages now. So the vessels, all of that happens due to hypoxia, because now we're under hypoxic conditions. Now the heart muscle is infracted, which means it doesn't get the blood it needs, because as we said here, we have an obstruction here. So this has blood, but all of this doesn't have blood anymore. So what happens is that the vessels, because we're not having blood, vessels or the system needs to find another way to give that infracted area some blood. They just need to get blood to that area. So the vessels start growing around the edges of the infract, and they start around the pale infracted areas. So new vessels just try to move around and play around over here just to get to the infracted area. So the monocytes uses these new weak vessels, because these vessels are new, they're trying to solve the problem, so they're new, they're considered weak, they're not tough, everything new is just weak. So the monocyte uses these new weak vessels to reach to the dead tissue. The scar tissue now will form, and that will be soft. And of course, if we start having a scar tissue now, it's only in the start, it's only in the beginning, so it's a soft scar tissue. This sets up for free wall rupture, because it's soft. That means we could have a rupture. It's not that tough. It cannot hold too much, so it could rupture at any minute. So that can lead to create a tamponade. If we have rupture, if it really ruptures, the scar tissue really ruptures, and the blood leaks from the outside to the outside, that would lead to cardiac tamponade. The cardiac tamponade is basically any fluid or blood, as we're talking, that is surrounding the heart and preventing the heart from contraction. So if blood leaks, then it would fill the periventricular space, and it would just prevent the ventricle from contracting. Okay. In addition, we can get false aneurysms, as we said, of course, since it only has 1 week layer with rupture. It would rupture easily because everything is still weak, so it could rupture at any minute. For the last period, and that is from 2 weeks to several months, now we can see that the great white scar started to occur. We have the contracted scar completed. Now it's tough, it's strong, it can hold better than before. For the complications, we could see Dressler syndrome. Dressler syndrome is, we're going to talk about, okay, I think it's here. Okay, so the macrophages are considered an antigen presenting cells, and they can present this cardiac antigen, like they do take some pieces from the heart itself and cardiac muscles, and they present it to the major histocompatibility complex, which will work, the major histocompatibility complex, whenever he sees those cardiac antigens, it will work with the T helper cells to activate the whole immune system. But unfortunately, the whole immune system is going to be activated against the cardiac antigens. So it's going to be activated against the heart itself. That's why it's considered type 3 hypersensitivity, and that is the Dressler syndrome. Back to the complications, all of it. We could have Dressler syndrome, we could have heart failure, we could have arrhythmias, and now we could have true ventricular aneurysm, and which has the risk of mural thrombus. So it's not like pseudo, as we just said in the previous period. No, this time it's true ventricular aneurysm that has the risk of mural thrombus. For the details here, that the macrophages start releasing transforming growth factor B. So macrophages start releasing some cytokine, let's say. It's the transforming growth factor B, and also there is platelet-derived growth factor, which tells basically the fibroblasts to make tons of collagen. Now we're asking, the macrophages starts asking the or ordering the fibroblasts, actually through these two, to make tons of collagen, and now we get the scar tissue that we needed, the tough hard scar tissue. This area cannot contract because it's a scar tissue. We know that scar tissue is just tough and strong and should not contract. It may bulge and create a true aneurysm, and when we say a true aneurysm, we know that it's made of 3 layers, so it's not only the inner piece or something. No, it's the 3 layers. So that's why it won't rupture easily. Okay, this sets up for a mural thrombus stasis that occurs since this area is hypocontractile. So we have the true aneurysm predisposes to mural thrombus and stasis because this area, this scar tissue area, is just hypocontractile and doesn't move a lot. Okay, another info here is that the metalloproteases, they convert the collagen type 3 to collagen type